This is Dr. Verlage again with our monthly lecture. Today is probably going to be a little bit on the shorter side. Topic for today is discussing the differences between postpartum depression and postpartum blues, here, normal postpartum adjustments. We'll throw in some other diagnoses quickly. But yeah, so let's move in. So, brief overview for today. Postpartum mood adjustments are very common. So 85%. I saw others, that said 75, but somewhere 75 to 85% of women will have some kind of mood disruption in the postpartum period. The vast majority of these are short-lived, not severe, and only about 10 to 15% of women actually move on to develop what we would call postpartum depression or postpartum anxiety. As many things in psychiatry, a lot of our diagnoses are a spectrum or a continuum. It's not as, regimented as it's this, then it's this, then it's this. And we're going to talk about that in a little bit. But as we move through all these diagnoses, think about it again, not only in perinatal psychiatry, but in psychiatry in general. A lot of things are on a continuum. So 3 main categories for today are postpartum blues, postpartum depression, postpartum psychosis, and also a little bit of talking about postpartum anxiety and OCD. So back to that discussion about the continuum. Postpartum blues would be considered the mildest form. Depression is more significant and more common than, and we're getting progressively less common as we go through these. Postpartum depression, more significant mood disorder, and postpartum psychosis is the most severe. So, as you can imagine, when we think about things in the continuum, there's gray in between, so as women transition from one to the other or land somewhere right in between, it can be, hard to decide, are we going to formally call this postpartum depression or not? Which is why when someone is starting to have mood disturbances, being aware of what to look for of signs that things are progressing and checking in regularly is really important to see, to catch them when they're on a point in that continuum where it is maybe more clear to you, or the patient has gained, importantly, the patient has gained that clarity that something is off. We have to screen, right? And we'll talk here in a second about how to phrase questions and how to think about questions can be important for us differentiating normal postpartum adjustments versus something more. And it mentions in that last point, we've talked about this in other presentations, depression, postpartum depression has negative effects on mom and baby. Needs to be diagnosed and treated as quickly as possible. So what would make us lean towards more of the postpartum blues? Again, postpartum blues, very common, up to 85% of women have it. It is because it is so common, it's considered a normal part of the postpartum experience. Interestingly, we think of moms feel sad. And actually, the more common symptoms reported with the postpartum blues is mood lability. That means rapidly fluctuating mood, tearfulness, and irritability. The symptoms of postpartum blues seem to peak around the 4th or 5th day after delivery and then seem to resolve within the first 2 weeks. This is a big point for psychiatry, again, in general. The impact, to me, is what guides when we diagnose or don't diagnose any condition, or when I'm talking about severity. In my mind, how has the mother's or patient's ability to function been affected? So, and you'll find this in the DSM-5, our diagnostic manual, that we have all these fancy criteria for whatever condition, but at the end, they almost always have a point of this must interfere with the person's day-to-day life and be distressing, right? So when a woman is saying it's hard to get out of bed, it's hard to take care of myself, it's hard to take care of my baby, that's really when we can feel more confident that this is kind of out of the range of that normal mood disturbance and into something that might need to be watched closer and treated. This last point is, so there's the functioning piece. There's also the time period piece. So we keep throwing this 2-week out there as a period of time that the blues usually go away. Interestingly, in our diagnostic manual, 2 weeks is the arbitrary, time point when we call a depressive episode, that it has to last for longer than 2 weeks. So it's a good time mark to keep as a relative guide. Someone's having awful depression with all the symptoms and it's been a week, I'm still going to treat it, But again, nice to know these parameters when we're, interacting with patients and trying to figure out what's going on. So here's that shout out to other common symptoms that maybe aren't discussed as much. Postpartum anxiety, very common. You can imagine a lot of new moms are anxious, but again, that functionality piece, you're so anxious that you have to check your baby every 30 minutes and you can't sleep. Maybe it's something more than, say, some anxiety, some normal anxiety that moms are adjusting to. We've talked about OCD, where, these new intrusive thoughts of, the two more common themes are harming baby and infection, or cleanliness and getting infected with something. Really important to note, again, these thoughts are very distressing, not something they're thinking about acting on, but not very common, but for new OCD diagnoses, postpartum is one of the most common time periods to diagnose it in. So we talked about kind of those detection challenges. For screening tools, the one that is used most often and in studies most well verified is the Edinburgh Postnatal Depression Scale. We've talked about it in some other lectures. Phrases questions in ways that helps us tease out those, normal postpartum demands and adjustments to something more. So a helpful tool. So then we move into that, on that continuum, the most severe form is postpartum psychosis. It is very, very rare. And it's interesting, we talk about it a lot, or I've talked about it a lot in these presentations, and it's not common. But, I think the risk that mom has to herself and to baby when it happens is dangerous enough that it's important to talk about so we know what to do when we see it. But yeah, 1 to 2 in 1,000 is how common it is. Usually onset is quickly after delivery within the first 3 days. Definitely usually within the first 2 weeks. We think of it as mostly women who have some kind of bipolar process going on. You can become psychotic with any, mood disturbance. It's more common in mania or mixed states, which is unique to bipolar disorder than depression. But regardless, the early signs of postpartum psychosis, restlessness, irritability, insomnia, those are also listed in postpartum blues. So again, those frequent check-ins to make sure that it doesn't progress. Other symptoms, the rapidly shifting depressed or elated mood, again, you can see that in other situations, but disorientation, confusion, erratic, disorganized behaviors. Biggest one, delusions, making statements about themselves or baby or things that just do not make sense, or auditory hallucinations. These two can be tricky for, when you're assessing any patient. So delusions, sometimes when people are talking to you, they say it so confidently that you're like, oh yeah, okay, I guess that's a thing. But if something feels off and doesn't make sense, whenever we're talking to patients, we need to be on the lookout. If some kind of sense tells you that what they said doesn't track with how you understand how things work, make note of it. Hallucinations, often they will just say, yes, I'm having hallucinations. Other times they might deny it, but then you see them do what we call responding to internal stimuli, which is kind of, talking to themselves. I'm sure you guys have seen it before with psychotic patients. Yeah, be on the lookout for those things. Any overt delusion, hallucination, as we've mentioned in previous, presentations, not something we figure out in a couple weeks, and it's an immediate need to go to the hospital. We treat that as an emergency. There is a baby who's quite vulnerable, at risk, and needs a lot, and someone who, probably isn't in a position to be able to take care of them as they need, but also a lot of delusions revolve around baby, can easily progress to revolve around killing baby. So, yeah, something that we don't mess around with. So what causes postpartum depression? We strongly suspect that hormonal shifts, postpartum hormones are going haywire. There's a dramatic fall in estrogen and progesterone within the first 48 hours. And some women are much more sensitive to this than others. In my experience, patients who've had hormonally, regulated or defined issues with mood in their life are much more likely to have it postpartum. For example, women with postpartum or premenstrual dysphoric disorder, meaning depression, anxiety, severe irritability in the days preceding their menses, are more at risk, or those who've been, say, very sensitive to birth controls, things like that, they're more likely than others to have postpartum issues in mood or anxiety. But then interestingly, seem to have a very stable pregnancy because their hormones are not fluctuating as much. They're high, but not fluctuating. So it's the fluctuation that really, sends vulnerable women and their mood and anxiety in a tailspin. So other contributing factors, marital dissatisfaction and or inadequate social supports seems to be something that can precipitate or contribute to that risk. Stressful life events during pregnancy or near delivery. Absolutely. And here's another point is deliveries often do not go as mom expected and often can be considered traumatic. So what in my definition is traumatic? Something that puts a person or someone they care about and love's life at risk and they don't have any control of the situation. In the algorithm of things that can happen during delivery, many deliveries have those two criteria. Now, does everybody develop PTSD? No. But, you throw in hormonal shifts with what can sometimes be a very traumatic event in delivery. Yeah. It's, again, one of the reasons why we see this trend of it not being uncommon for postpartum depression and anxiety to develop. Again, another principle that is mentioned here, but applied to general in psychiatry, is underlying vulnerability. So the, nature versus nurture debate. There are genetic predispositions and epigenetic predispositions to different conditions. PTSD, depression, anxiety, OCD, schizophrenia, you name it. And under the right, or I would say wrong, circumstances, that nature part, it brings out the condition that they're already predisposed to. Not only the event, also, that epigenetic piece of, childhood exposures. So it's all those things combined. The genes, the childhood, and how that interacts with the genes, and then the event now that contribute to people developing or not developing a disease. And sure, some may lean more on the genetic side, some more on the, and the nature side, some more on the nurture and childhood side. But at the end of the day, it's a dance between all the three. So also something to keep in mind when we're working with patients and thinking about their risk level. So who is at risk? All women. There is no socioeconomic, education, marital status, what have you, group that isn't at risk. Can happen to anybody. Those, factors that we have more data to support that they are risk factors: a previous episode of postpartum depression, depression during pregnancy, any history of depression or bipolar disorder, a recent stressful life event, and inadequate social supports, kind of leaning on some of the other stuff we've talked about. So in conclusion, it's important for us to screen and support our moms. Everything's on a continuum. It can sometimes be tough to know where they land on the continuum, and that's okay. Frequently check in with them, see how their functioning is. Shout out to anxiety and OCD. Those happen too, something to watch for. Recognizing things early and so that we can intervene early, super important. It's, as we've talked about in other presentations, not good for mom or baby for it to be left unaddressed. These talking about it, normalizing that it happens, can all be things to help us, help women feel comfortable recognizing or be able to recognize it and be comfortable asking for help. So, all right. Well, thank you for your time, and we'll see you at the next one. Have a great day.